Hey, good evening, everyone. Thank you all for joining. Those of you who have joined live, and then to anyone who's watching on YouTube, thank you for watching as well. My name is Sivakanthan. I'm Dr. Baj's fellow this year, so I'm at the University of Arizona at Banner in Phoenix. I trained at the University of Washington, grew up at Harborview Medical Center, and spine trauma is really the reason I switched from being a cranial neurosurgeon to a spine surgeon. So I wanted to kind of get back and give a talk on spine biomechanics and spine trauma. So just by way of outline, I'll start by talking about some basic physics just to kind of as an overview. We'll move then into biomechanically relevant anatomy, and then finally biomechanics of spine trauma and some of the different classification systems that are used and how to best utilize them. So let me just kind of start by saying I am by no means a physicist. This is essentially just to establish a common language and go over some principles that are relevant to spine and spine trauma. So when it comes to motion in the spine, there are different planes, and the primary planes of motion are flexion and extension, lateral bending, and rotation. But in addition to overall global planes of motion, there is also segmental planes of motion, and that could be translation, which is movement along an axis, rotation, which is movement around an axis, and the combination of the different axes results in 12 possible movements. So 2 translational and 2 rotational movements along each axis. And these translational motion occurs when a force pushes a vertebral body in the same direction. And any force that causes this type of translational motion is called a shear force. Whereas rotational movement occurs when at least 2 forces act on a vertebral body at different points, and this causes it to rotate around a fixed point within the bone. The movement of each point forms an arc, and the points from different centers of the different distances from the center of the motion have different arcs. When 2 rotational movements are applied to the same body, these are called coupled forces. When it comes to rotation, you also have to define the instantaneous axis of rotation. The IAR is dynamic, and it depends on the intrinsic curve of the spine, as well as different factors that are variable to each individual, like degenerative disc disease, fractures, ligamentous injury, and instrumentation if it's present. Usually this falls within the vertebral body, somewhere within the vertebral body in the sagittal plane. And the instantaneous axis of rotation is always perpendicular to the plane of the rotations. Thus, there is no net force at the center of the rotation. Talking very briefly about kinematics and kinetics, a force applied in a direction results in a vector. And a vector can be applied to a lever or a moment arm that causes a bending moment. So essentially, think of the motion of a screw. There's a bending moment and a force applied to that moment over the length of the lever arm, and that results in torque. The torque is usually the result of 2 opposing forces generated by different muscular action, or it can be the result of 1 force and 1 resistance, and that resistance can also be gravity. When a bone rotates around different points and has different rotational exertions, but all points around rotate in the same plane. Going on to biomechanically relevant anatomy and applying these kind of physical principles to our kind of biologic anatomy, we can start at the top of the skull at the cranial cervical junction, and we see the foramen magnum is formed completely by the occipital bone. And this is something that we often kind of either take for granted or forget to appreciate. It's formed by the squamosal bone dorsally, with the posterior margin of the squamosal bone being the opistheon, and the clival bone ventrally. The 2 occipital condyles form the lateral aspect of the foramen magnum, which contain the occipital condyles formally, the jugular foramen, and the hypoglossal canals. If we move further down into the atlas is a ring-shaped bone without a true vertebral body and a spinous process. Instead of a vertebral body, it has two paired lateral masses that are connected by an anterior arch and a posterior arch. In lieu of the body, there's the dens of C2, which articulates at the facet for the dens. One kind of clinically important principle here is Steele's rule of thirds, which states that the volume within the atlas can be divided into three parts. One part is the posterior part is the CSF, the middle part is the spinal cord itself, and then the anterior part is the dens. And this has clinical significance when you're dissecting down or instrumenting or dealing various pathologies of the atlas. Down to the axis now, the axis is formed by the anterior odontoid process, or the dens, which projects superiorly from the body, and then there are the two oval facets ventrally, which articulate with the atlas at the anterior arch. Dorsally, there is the groove for the transverse ligament and the various other ligamentous attachments, which we'll get into in a later slide. And then there's the paired lateral masses with the transverse foramina, where the vertebral artery obviously runs. This notably is the first bifid spinous process, which obviously we all know when we dissect down to use as a landmark for our dissection. In terms of the ligamentous anatomy of the craniocervical junction, it is quite complex, but boils down to essentially the alar ligament and the transverse ligament forming the transverse alar complex, and the majority of the ligamentous stability of the spine. In the subaxial cervical spine, there's a relatively uniform segmental anatomy with facets oriented in the coronal plane. At the cervical thoracic junction, the angle between the facets and the joints changes relatively drastically, predisposing to traumatic injury. And this is a concept that will come up later on the road when we look at the thoracolumbar junction. Anywhere where you have a change in the angle between the facets and the joints induces more stress and predisposes to traumatic injury. When it comes to the biomechanics of the cervical spine, in the neutral position, the facets are unloaded. But in lordotic, in the normal lordotic spine, the facets are loaded and thus subject to injury. The atlanto-occipital atlas complex is the most mobile part of the adult skeleton. About 25% of flexion extension comes from O to C2. And about 90 degrees of rotation comes from the AA joint. So it's a hugely mobile part of the spine. Notably, vertebral artery occlusion occurs around 30 to 35 degrees of rotation. So something to keep in mind when we see traumatic injuries, particularly with a rotational component. Moving down to the thoracic spine, again, it's very reproducible in segmental anatomy. You have paired pedicles, a lamina, a large vertebral body. The thoracic spine is unique in that it has a superior and inferior costal facet where the ribs articulate, leading to kind of internal bracing of traumatic injuries there. And this is a figure from Dr. Baj's paper illustrating the very kind of reproducible anatomic entry points and trajectories for thoracic instrumentation, just illustrating how segmental the anatomy is. In terms of biomechanics, the normal curvature of the thoracic spine makes it pretty prone to axial loading injuries. But again, it is shielded from destabilizing injuries by the rib cage and the paraspinal muscles. Having said that, the spinal canal diameter is smallest in the thoracic spine. So while there's a lot of kinetic energy required to destabilize, once that energy is achieved, it's a relatively high probability of a devastating neurologic injury. Then shifting our attention to the thoracolumbar junction, here the rib cage no longer provides any support. And the kyphotic curve of the thoracic spine rapidly transitions to lordosis, predisposing it to axial loading type injuries. Here, the vertebral body size is also not as large as in the lower lumbar spine, and thus the spine is more vulnerable to axial loading injuries. Down in the lumbar spine, the vertebral bodies are significantly larger, leading to resistance to axial loading. There's also a resumption of a lordotic curve. However, in addition, the spinal cord ends and the cauda equina begins, which means it's more resistant to neurologic injury. But again, the orientation of the facets makes them more prone to translational deformity. So moving into the biomechanics of spine trauma, before we understand what is instability, we have to define what is stability. White and Punjabi originally defined stability as the ability of the spine to undergo physiologic loads to limit patterns of displacement so as not to damage or irritate the spinal cord or nerve roots. And thus, instability is the inability to limit excessive or abnormal spinal displacement. So there are different types of instability that have been described, acute and chronic. Acute is obviously what we're talking about here in trauma, with overt instability being inability of the spine to support the torso during normal movement, versus limited instability, which is defined as the loss of either ventral or dorsal spinal stability. Chronic instability is more in our kind of degenerative world, with glacial instability and dysfunctional motion segments having been described in the literature. Many different quantification metrics or schemes have been developed. White and Punjabi were the first, obviously, with their kind of framework being described there: anterior elements, posterior elements, rotation, core damage, etc. The Denis three-column model is a very simplistic and easy way to understand stability, and that's essentially that the spine can be divided into three columns: anterior, middle, and posterior, as you can see there. Injury to two out of the three columns is a potentially unstable. Injury to three out of the three columns is grossly unstable, and then injury to one out of three columns is essentially a stable injury. When we talk about injuries to the spine, we should also talk about load sharing. And in the normal kind of physiologic state, 80% of the load is absorbed by the anterior and middle column of the spine, and whereas 20% of the load is weathered by the posterior elements. This obviously changes with different pathologies, and specifically in pedicle screw instrumentation, the differential is more or less 40-60, 40% of the load being shared by the anterior columns versus, 60% of the load being shared by the anterior column versus 40% of the load being shared by the posterior elements. This can be augmented, for example, in this picture, using segment to provide additional load bearing to the anterior column. But in general, it's about a 60-40 split. So the question becomes, in trauma, how do you quantify load sharing, and how do you define what patients would need anterior column support? And this is where the McCormick-Gaines classification comes into play. They looked at comminution, apposition of fragments, and reducibility of sagittal deformity, and formed essentially this quantification scheme. The more comminuted, the less opposed, and the more kyphotic deformity, the more likely someone would need an anterior approach. And essentially, a score, numerically, a score of greater than 7 would require an anterior approach. And with that, the next kind of schemes that have been developed are the TLIX and the SLIC classification systems. TLIX being a thoracolumbar injury classification system, and SLIC being the subaxial injury classification system, both of which essentially look at the same three categories. The first being the morphology of the fracture. Is it a compression fracture? Is it a burst fracture? Is there a distraction, or is there translation? The second being the integrity of the posterior ligamentous complex or the discal ligamentous complex, whether it's intact, suspected, or injured. And the final component being the neurologic status of the patient, whether they're intact all the way up to incomplete cord injury or cauda equina. These classification systems can then be summed into non-surgical 0 to 3, surgical greater than 4, and then essentially dealer's choice at 4. I think these are relatively well known and relatively well utilized. I would say that in my anecdotal experience, the majority of pathology I see ends up being a 4. So I have not personally relied on these to guide my practice. The AO classification, however, I have adopted in my training at Harborview. We were very AO heavy, and we did cite AO classifications for all of our fractures. It is something that I encourage all my residents here to learn and utilize in their day to day. Starting up at C12, fractures can be classified under the Anderson-Montesano classification. Type 1 fractures being impaction fractures, where axial stress causes essentially an impaction injury around where the alar or tectorial membrane would insert. Type 2 fractures are fractures of the base of the skull, which then extend into the condyle, and generally speaking, these are relatively stable. And then type 3 fractures are avulsion fractures, where the insertion of the alar ligament has been torn. Odontoid fractures, moving down to C2, are some of the most common types of C2 fractures or Dens fractures, and these follow the Anderson-D'Alonzo classification. A type 1 fracture is a fracture of the upper part of the odontoid. The type 2 fracture is a fracture of the base of the odontoid, and finally, a type 3 fracture is a fracture of the odontoid through the lateral masses of C2, and that one generally has the best prognosis for healing. Moving to ring fractures, the Jefferson fractures or complete or incomplete ring fractures follow the Levine and Edwards classification. As you can see here, the type 1 fractures are generally posterior arch only. Type 2 fractures are anterior arch only. Then you have a complete dissociation fracture like type 3, or unilateral floating lateral mass like type 4. At C1, C2, you can have combined fractures, or also C2 hangman fractures, which fall into the Levine-Effendi classification. I won't go through the entire chart here for you, but essentially it comes down to greater or less than 3 millimeters of subluxation, or greater or less than 15 degrees of angulation. And as what it breaks down into is essentially the more angulated the fracture, or the more displaced the fracture, the more likely the fracture will require operative fixation. So with that, the AO classification kind of adopts these previously named classifications and breaks it down into essentially progressively worsening type A, type B, type C fractures of the occipital condyle, cranial cervical junction, the ring and the joint, and finally the C2 as well as the C2-3 joint. Moving on to, so in terms of how do you determine what fractures need an operation and what don't, you can look at these normative measures of craniocervical instability. For example, your atlantodental interval, basiodental interval, your basioaxial interval, the C1, C2 interval, your rule of Spence and Powers ratio. And these, although they have been traditionally described on X-ray, can be measured on CT scan now as well. And they provide a very kind of quick and dirty, is this a stable or unstable type of injury? Moving into the subaxial cervical spine, the AO classification groups these into 5 different groups. The compression type injuries are the type A group. And these are from axial loading type injuries. A0 are non-structural injuries. They're spinous process fractures, transverse process fractures, laminar fractures. These are non-destabilizing type injuries. A1 type fractures are wedge compression, and they usually involve just one end plate, but they do not involve the vertebral body posterior wall. Split fractures can occur either in a coronal or sagittal plane, and they involve both end plates, but do not have posterior wall involvement. And finally, are your burst fractures, which can be incomplete or complete, with incomplete involving only one end plate versus complete involving two end plates. Type B type injuries are tension band injuries, where B1 involves just the bony tension band, so a pure osseous fracture with physical separation of the bony structures. B2 injuries are posterior tension band injuries, where there's either capsule ligamentous or bony capsule ligamentous injury, versus B3 injuries, which are anterior tension band injuries with physical separation of the anterior structures with an intact posterior band. There are also C-type injuries and BL injuries, BL being bilateral, so bilateral lateral mass injuries, and then C-type being translational and obviously highly destabilizing injuries. Finally, there are the facet injuries. They start as kind of insignificant as non-displaced facet fractures with less than 1 centimeter fracture size, with less than 40% lateral mass involvement, versus and then progressively increase into more destabilizing injuries, such as facet fractures that are potentially unstable, greater than 1 centimeter displacement, and greater than 40% lateral mass involvement. Floating lateral mass fractures due to fractures of the pedicle and lamina. And finally, a fracture subluxation or fracture translocation, which can be highly destabilizing and require potentially closed and then open reduction. And then moving into thoracolumbar spine, the same type of A to C type fracture patterns have been described. With A0 type fractures, again, being not minor, non-structural transverse process fractures, spinous process fractures. A1 fractures are, again, wedge compression injuries, which are single end plate involvement. A2 are your split fractures with both end plates and an intact posterior wall. And anytime a posterior wall is involved, it's a type of a burst, either a single end plate with posterior wall being an incomplete burst, or a complete burst with both end plates of posterior wall fracture. B-type injuries are your distraction injuries, which involve both anterior columns or one anterior column and a posterior tension band. The B1 are your pure transosseous injuries involving the vertebral body, the pedicles, and the spinous process. B2 are your osteoligamentous fractures, either involving a vertebral body or a spinous process fracture with a coincident ligamentous injury to the other column. And finally, B3 are your hyperextension injuries with anterior tension band injuries extending into the disc and body. Finally, your C-type injuries are your translational injuries, again, similar to your cervical spine, and these are classified by displacement in any direction. And these, again, are highly destabilizing and surgical injuries. The AO classification also has a neurologic status component, as well as some modifiers, very similar to the TLIX or SLIC score, taking into account whether the patient's intact or if they have neurologic signs, radiculopathy, or complete spinal cord injury. And your modifiers include tension band injury on MRI, or comorbid conditions such as ankylosing spondylitis, which obviously changes the game when it comes to fractures and fracture management. These are long bone injuries and should be treated as such. Osteopenia, osteoporosis, overlying burns, etc. They also have a scoring system, and their scoring system essentially breaks down to 0 to 3 being conservative, 4 to 5 being operative or non-operative. Essentially, again, dealer's choice, and greater than 5 requiring surgical intervention. So that's all I really had prepared. I'm happy to answer any questions. I'd like to thank Dr. Baj for giving me the opportunity to talk, and it's this is a lecture series that I've certainly relied on in training to glean a lot of information from, and happy I could contribute in my way. If you're able to help with the chat, I'm not able to see.
Thank you so much, Dr. Sinan, for the great session.
Yeah, of course, no problem.
There is no question in the chat box. Amazing session. Thank you so much.
Of course. Thank you,
Yeah.
everyone. Have a good night.
Bye-bye.